Our first ask is requesting that your member of Congress co-sponsor legislation related to Graduate Medical Education, or GME, the Resident Physician Shortage Reduction Act of 2017. As you probably know, the majority of public funding for GME comes from federal government through Medicare. Additional sources of GME funding include Medicaid, private payers, Veterans Affairs, and other state and federal programs. This investment reflects our understanding as a society that we all benefit from a skilled physician workforce, so the government should subsidize it. Adequate GME funding is essential to training a workforce to meet the needs of our population. Unfortunately, the way we fund GME is no longer adequate. In the coming decades, the United States will face a projected shortage of both primary care and specialist physicians, including cardiothoracic surgeons. Robust forecasting of physician supply and demand from a recent report by the American Association of Medical Colleges identified a projected physician shortfall of 40,800 to 104,900 physicians by 2030. Analyses commissioned at the state level overwhelmingly support this conclusion, with 33 states identifying current or future physician shortages, including a nationwide shortfall of at least 1,500 cardiothoracic surgeons by 2025. Specialty workforces such as cardiothoracic surgery are particularly vulnerable to a shortage due to the long training time and high debt load. The number of practicing cardiothoracic surgeons is decreasing. There are currently fewer than 2 practicing cardiothoracic surgeons for every 100,000 Americans, with most of the surgeons concentrated in urban areas. That ratio is expected to worsen as more than half of the current cardiothoracic surgeon workforce is 55 years and older, with a large number expected to retire over the next decade. Meaningful GME reform must address these issues. The physician shortage is driven by many factors, including an aging population and the retirement of senior physicians, an outdated cap on resident positions, a geographic maldistribution of specialists, and the ever-increasing technological proficiencies necessary to be competitive in the field. The federal cap on residency positions was established by Congress in the Balanced Budget Act of 1997. Congress capped the number of residency positions that Medicare would support at the number of residents who were training in a given teaching hospital as of December 31, 1996. Any new trainee position created after this 20-year-old cap is not federally funded. Because of the cap, the number of thoracic surgery training programs has remained fairly constant since the late 1990s. In contrast, medical schools increased enrollment by 25% between 2002 and 2015 in an attempt to address the projected physician shortage. As the number of medical school graduates increases and the number of GME training programs remains stagnant, there will soon be a shortage of GME training opportunities for newly graduated physicians across all medical specialties. As with any policy problem, many different solutions have been proposed. Listed here are just a few of them. One obvious answer is to raise the cap on the number of residency positions that Medicare will reimburse hospitals for. Another idea is to pursue loan forgiveness and/or deferment programs, which would particularly benefit those pursuing surgery, with its additional years of training and subsequent additional loans. Since the workforce distribution is also a big problem, it would behoove society to investigate the geographical and economic factors that are contributing to the workforce shortage, including a redistribution of residency positions within cardiothoracic surgery programs, pathways of unmatched cardiothoracic surgery applicants, and options for increasing cardiothoracic surgery programs in underserved areas. The Resident Physician Shortage Reduction Act directly tackles one aspect of the shortage, the federal cap on GME positions. The bill increases the resident limit for qualified hospitals by 3,000 per year for 5 years. Half of that increase must go towards shortage specialty residency programs like cardiothoracic surgery. The bill also attempts to address concerns about appropriate distribution of GME slots by directing the Comptroller General to conduct a study on strategies for increasing the diversity of health professional workforce, including an analysis of strategies for increasing the number of health professionals from rural, lower income, and underrepresented minority communities. This bill has been introduced every year since 2009. Last year, the legislation amassed 16,000 co-sponsors in the Senate and 143 in the House, so we know it appeals to a lot of members. We will let you know whether any of the congressional officers you meet with were co-sponsors last year. STS has endorsed it repeatedly because of its multi-pronged direct approach. While not the end-all be-all for addressing workforce issues, it is a positive step. We are hopeful that the emphasis on passing healthcare legislation will finally get us over the finish line this year. We hope that you will ask your members of Congress to become co-sponsors and help this bill become law.